Hello, everyone. Today I want to talk about some work by me and my colleagues at Yale. I want to begin with a scenario. A pediatric trauma alert rings overhead. You enter the room to find a 3-year-old victim of a rollover MVC. As the patient is hooked up to the monitor, you realize he is crashing. He has a deformity across the chest wall and is extremely tachypnic. A resident places an ultrasound probe on the chest, and it's clear that there is no lung sliding. Meanwhile, the patient continues to decompensate. You need to intervene. What do? You decide that you will needle decompress. But what type of needle do you use? This is the clinical question we studied. What size needle should we use when performing needle decompression in children? You might expect there are some guidelines that address this question, but you would be wrong. ATLS recommends 8 centimeter needles in adults, but gives no specific recommendations for children. More recently, 2 studies came out over the past year which reviewed CT scans of children who underwent imaging. These studies demonstrated that an 8 centimeter needle, if used in children, poses significant risk to damaging vital structures. These studies also measured the chest wall thickness of pediatric patients, but many of those kids were cancer patients and positioned uniquely for the CT protocol, so it's unclear what to make of their data. There's also been a shift in the adult guidelines from performing needle decompression at the second intercostal space at the midclavicular line, which is the classical approach, to the fourth intercostal space at the anterior axillary line, where recent studies show that the chest wall is thinner. So one of our secondary aims of our study was to see if this holds true for kids as well. So we decided that the best way to answer our clinical question was to prospectively measure the chest wall thicknesses of pediatric patients we see in our emergency department. We measured at both the anterior axillary line as well as the midclavicular line and on each side, left and right of the patient. The modality we used was point-of-care ultrasound, and we measured the perpendicular distance from the skin to the pleural line, as you can see on this image on the right. Our team consisted of 4 ultrasound-trained investigators under the supervision of 2 pediatric EM ultrasound faculty. Our researchers all watched a training video that demonstrated standard technique, and scans on volunteers showed a high inter-rater reliability between our sonologists. Ours was a cross-sectional study design where we enrolled a convenient sample of patients who passed through our pediatric ED. Altogether, we enrolled 163 patients. The Table 1 of our study shows that the distribution was not exactly equal, but rather reflected the demographics of our particular emergency department, with fewer infants and toddlers and more school-age children. Still, we made sure to have at least 10 patients in each of the 9 Broslow categories, and these altogether totaled 118 patients. In addition to those patients, we had 45 who were larger than the Broslow category, and we analyzed them as a separate category altogether. Moving on to the actual results of the study, here is the chest wall thickness for each Broslow category, with corresponding confidence intervals and broken down by site as well. Now there is a lot of data on this slide, but the one value I want you to keep in mind is 3.175 centimeters. That is the length of a standard IV catheter. As you can see, the chest wall thickness of each of the Broslow groups is less than 3.175 centimeters. So that led us to our primary conclusion, which is that the standard IV catheters we stock in our EDs for blood draws and IV infusions, those catheters are long enough to reach the pleural space with some added margin. Those standard length catheters are 1.25 inches or 3.175 centimeters. Now, one caveat to our study was that we did not examine anything about the optimal gauge or caliber of the needle. So whether a 14 or 16 or 18 gauge needle is best, that's a separate question left for another study. Some other findings we found were that, at least in kids, there was no significant difference in chest wall thickness at the anterior axillary line versus the midclavicular line like we find in adults. nor was there any significant difference based on the right or left side of the patient, nor between males or females. We did find a moderate correlation between increasing weight and chest wall thickness, which you would expect given the increasing fat and soft tissue in obese patients. Finally, we asked how the standard length catheter would fare on those kids greater than 36 kilograms. This is an increasingly important consideration given the rising prevalence of obesity in kids. What we found was that even in this larger sized cohort, a standard catheter was long enough for the majority of cases. The dashed line represents the standard catheter length on this box and whisker plot. And as you can see, it's greater than 75% of cases. So, of course, our study has some limitations, and I've outlined those below, but I don't have time to go into them right now. But what I wanted to leave you with was the take-home point of our study, something you can turn to when that pediatric trauma victim arrives and they have tension pneumothorax. Based on our findings, our advice is to reach for the standard length catheter, which should be deep enough to successfully perform needle decompression. I want to thank my co-authors on this study, and I also want to thank you all for listening.